And it is time that we go for the discussion and the question answer segment. So over to the respected panelists and the chairpersons.
Dr. Mona, any comment?
No, actually, all of the speakers have done a great service to their topic. But I just wish they could be particularly specific about patient that was being put up. The discussion discuss what to do with this patient. So the speakers can take it up.
Okay. I think Dr. Somo has done his right job regarding follow-up treatment and other things. And regarding initial presentation by Moinak, I will ask him one thing. What is the probability, clinical probability of heart failure? Dr. Sina has elaborated to other areas also. It can be a pulmonary cause, it can be a cardiac cause, or a combined cardiopulmonary cause. Considering this dyspnea for 7 days, and that is worsened acutely and presented with a severe hypoxia, 84% SpO2 in room air. And what is the clinical probability and pedal edema JVP raised?
The maximum clinical
probability of having heart failure.
Yeah,
probability of heart failure or non-cardiac cause. What is the probability?
Yeah, the maximum possibility that this is a case of biventricular failure, because patient is having dyspnea along with hypoxia, along with raised JVP, with pedal edema, with subacute onset of presentation, with acute deterioration, with very much high raised NT-proBNP. So everything goes more in favor of heart failure.
Do you apply any RIG score, like best score like this?
We can apply it, but my task was to discuss the immediate management in ER. So that's why I discussed
regarding immediate management in the emergency. What will be your initial 2-3 investigations? First, 1, 2, 3.
Yes, sorry, ECG, TROP-T, and chest X-ray. So these are the all
any
three
role of
things that are available everywhere.
Considering hypoxia, any role of ABG, arterial blood gas?
Yeah, ABG definitely can be done, but as I already am having the 84% of SpO2, so definitely firstly I will try to elevate the symptom of the patient at first.
Yes, sir. Role of chest X-ray, immediate chest X-ray?
Yeah, chest X-ray definitely it has got role, because I will get about the idea of the congestion, pulmonary venous hypertension. I can get an idea about that. I can get the batwing pattern typically in the chest X-ray. Also, I can get the idea about the cardiomegaly, whether there is or not, and that can give me an idea about the chronicity of the disease. And another thing that I will keep in mind about the aortic shadow, because sometimes acute aortic presentation can present with this kind of presentation also. So I will also,
that means,
and also I will be able to exclude some other chronic pulmonary pathology also.
Yes, that means X-ray has got a tremendous value. ECG can rule out an acute coronary event also, and ABG can guide you regarding whether you will go with NIV or intubate it. If the patient is severely acidotic, suppose pH is 7.1 or 7, then you cannot wait. You have to give some support very quickly, because there is an acute deterioration with SpO2 of 84%. So ABG has got a tremendous role, ECG and X-ray. I think these are definitely the first line investigation. I ask Dr. Jayanto Sharma to comment something regarding this immediate management. What will be your advice to the resident of the emergency regarding management of this patient? Anything else you will add?
No, sir, Prakash sir, what about that? If any patient comes in the emergency and these things in ER, if this type of patient comes, the first things we have to do that, as you have been told, do the ABG first. And along with the ABG, definitely you have to go for the chest X-ray, because ABG gives, as you have been told, whether we should give the patient the NIV support or only oxygen support or give the bed mask support and these things. After the initial stabilization of the patient, then we have to think about what are the other causes of the cardiac failure in this patient. And as Dr. Ashish Sinha has told, besides the cardiac cause, we have to think about the non-cardiac cause also. As to the non-cardiac cause also, we have to do the ABG first in this emergency patient in ER.
I will ask Dr. Somo to, a question has been put forward by the attendees, that do you prefer IV infusion in the diuretics as an IV infusion or as a bolus dose? And another question was put, that is furosemide versus torsemide. You have given the answer already in
Yeah,
your presentation.
I have already mentioned in my
Ah.
topic that these are similar,
Similar.
but definitely with a significant volume overload, we generally prefer to have an infusion to be started first. When the hypervolemic status is almost euvolemic, you can shift to the injectable in a divided doses. It may be torsemide, it may be furosemide. Both these drugs are almost having the similar efficacy.
That means you are preferring infusion.
To start with, definitely infusion is better.
Any hemodynamic benefit? Any
if the
hemodynamic
patient,
benefit?
yes, and if the patient has received diuretic, often the infusion and the higher dosage of diuretics definitely gives us better. And there is data that even if we use in early CKD, that means the creatinine in the borderline, if the creatinine clearance is in the gray zone, that means 45 to 60, it may increase the creatinine level in those patients, but it may revert back to normal if we stop those injectable infusions or the injectable diuretics within 1 or 2 days.
I will ask Moina to answer one thing. How will you assess that patient has become euvolemic? What are the parameter you will judge and think that the patient has become euvolemic?
Yeah, sir, am I audible, I think?
Yes.
Yeah. So clinically, I will evaluate for the pedal edema and the JVP and the basal rails. And also I will daily monitor the body weight of the patient and along with the urine output.
Okay. Any role of chest X-ray?
Why should I regularly expose my patient to the radiation just to
Okay, we will avoid. Any role of chest ultrasound?
Yes, sir.
Yes,
The
ultrasound can be
P line
done.
in ultrasound is important in that.
Yes.
Ultrasound
If you want to
definitely can be
avoid X-ray, you can go with ultrasound to see the cardiac lines, and also you can evaluate regarding any pleural collection, that means any effusion is there or not. That can be. Another thing is IVC diameter.
In echo, we can easily evaluate it.
IVC diameter.
Clinically, it can be evaluated easily.
Yes, these are the parameters. If it is satisfied, and along with, if you can go for NT-proBNP level, what is the Indian level that when a cutoff value you will accept that the patient is euvolemic? In some of the international trials, there is saying 500, some trials saying 250, even 100. What you accept as an Indian for this cutoff?
I am not aware of any definite Indian cutoff value, but what is actually written in the guideline is the serial going down of the NT-proBNP is more important than any specific particular value.
It is going down. Suppose it is 600, another person is 400, which is
it also depends upon the baseline of the patient and also the age of the patient also.
That means
another important thing is, Prakash sir, which laboratory you are doing and which setup you are working, because each and other hospitals are having their own criteria, and the lab parameters depends upon the reagent also. So
and in obese patients, sir, we must have a false negative report too. So in obese patients with a heart failure lady, specifically the elderly obese ladies, we may have a false negative NT-proBNP level.
Yes, that's why the guideline has been published in 2022 that GWTG, that is AHA, that is it is get with guidelines heart failure. Get with guidelines heart failure. That is for non-cardiac area. That if there is no comorbidity like chronic renal disease, that means chronic renal parenchymal disease, that is CKD or CLD, morbid obesity. This, if we rule these three, cutoff value is less than 400, otherwise less than 1000 is acceptable in these three groups. And that's a guideline published by AHA. There is get with the guidelines heart failure, GWTG guideline. That is acceptable regarding NT-proBNP, acceptable value regarding euvolemia. So we can go with that. Anything that, do you prefer to, suppose the patient is not responding well to diuretics. I will ask Dr. Sinha also to comment on this, that if the patient is not responding, suppose even after giving diuretics and infusion, it is not responding for next 24 to 48 hours. Do you consider for ultrafiltration?
One thing I would like to suggest, sir, that if my patient can have 2 or 3 comorbid conditions together. It could be a cardiac disease with a pulmonary causes and could be a non-pulmonary cause. The presentation does not specifically stick to just one diagnosis. So my patient might be having a cardiac failure. He could be having an interstitial lung disease with something else. So now, whenever we are evaluating the patient, if we are just treating on one aspect or maybe just specifically on diuretics and we are not getting benefit as we are expecting, we should always look for other parameters, other things which could be an underlying cause of the breathlessness. As I have elaborately told that there could be multiple causes of dyspnea. So as we have host of hundreds and hundreds of reasons for dyspnea, my patient could be having 3 or 4 conditions that could be the reason for not getting benefit out of what we are getting. So yes, as you said, sir, there's a lot of noise anyway. As you said, sir, there is chances for ultrafiltration, considering we know the etiology of the dyspnea. So if we know the etiology of the dyspnea, definitely it's going to help us. So that is what I would like to
Somo,
cover.
any comment regarding ultrafiltration? Somo?
Sir, ultrafiltration we have learned after the COVID era only. So
Yes.
the role of ultrafiltration is definitely there in patients with decompensated heart failure in diuretic resistance. But before calling a patient diuretic resistance, we must give them a higher dosage. I have seen nephrologists prescribing diuretics of 200 milligram a day, adding other diuretics apart from the loop diuretic. There are trials that we may prescribe number one the drug I forgetting this one, the acetazolamide.
Yes.
Acetazolamide can be taken according to the advert trial has come that we may prescribe injectable acetazolamide in those patients first. Number two, we may shift to the hydrochlorothiazide diuretic add-ons on the loop diuretic. Then only we can stamp one patient that the patient is having diuretic resistance, and then we may shift from the DCT to PCT. That means those diuretics working on the distal convoluted tubule, we can shift to other diuretics that works on the proximal convoluted tubule. And if still the patient is hypervolemic, we can't give albumin. Otherwise, in those patients with normovolemic or hypovolemic patient, we can start with a low dose albumin too. So apart from these trials, we may shift to the ultrafiltration definitely, and it helps in prevention of heart failure related hospitalization and prevention of acute decompensation over
Final comment from Moinak regarding the acetazolamide. He has given 2-3 slides. I think
Yeah.
he has not elaborated, but I think I'll ask Dr. Moinak to clarify that thing that's as
Yes,
use of acetazolamide.
yes, sir. In that particular advert trial, where the total number of patients was something around 450, it was found that IV acetazolamide, when it was used along with IV furosemide, the effect was good. Patient been on lesser amount of the hypervolemia, and they went into hypovolemia much earlier. They got to be discharged earlier. But again, as the number of patients was low, so hence, as per the 2023 updated guideline from ESC, they still don't recommend it, but further study has been recommended over that. But definitely, it's a good outcome, obviously.
Any role of digoxin? When to use digoxin?
In acute
Somo has
setting,
given
yes.
on slide regarding digoxin.
Yeah, so digoxin is the last option, definitely class 2B indication. But what I think, in ejection fraction of less than 20% with a hugely dilated heart, with a LVIDT of more than 55 or 60, with a atrial fibrillation which is not controllable, which is permanent, stamped permanent, we can try with a digoxin. And specifically in the Indian scenario where the rheumatic heart disease is prevalent, definitely digoxin has a good role in heart failure. So but before prescribing digoxin, what I suggest that we must screen the LMCA disease, because if we prescribe any patient with LMCA or LMCA equivalent disease digoxin, that may end up in catastrophe. So that
means we can enter into the interventional field. What are the indications for coronary angiography now? Then, when in a patient of heart failure, we have to suggest coronary angiography.
Yes,
Then what are the things we should look for that this patient definitely needs an coronary angiography?
Okay, so in that case,
From ECG, echo, and everything.
yeah, sure. First, the clinical evaluation should be done. Background risk factor of the patient and any previous history which is suggestive of ischemic heart disease, angina or angina equivalence. Along with that, whether there is any ECG suggestion of any ischemic heart disease or echo, but sometimes it may be possible that the ECG and echo both are completely normal, but the patient's background history can have some clue of coronary artery disease. in that case, definitely it is important to rule out with a coronary angio to rule out the ischemic etiology of heart failure. Definitely.
Even a new onset arrhythmias, be it a paroxysmal AF or be it a NSVT run, too leads to an indication of.
Yes. These are basically strong indication for coronary angiography. And this, what is the threshold for revascularization? Suppose your patient is ultimately diagnosed to have a DCM, dilated cardiomyopathy. Now you have to decide for revascularization.
So we have trials, teaches 10 years outcome trials are there. We have BCIS2 trials. So definitely revascularization with a CABG has a good outcome. Only the reperfusion can be achieved properly. In single vessel disease with a LV apical aneurysm like LAD in the distal LAD territory, we can revascularize. It has a good outcome. It is established. But in triple vessel disease, once the revascularization is performed, it should be done ideally with a CABG, not by a PCI. PCI has not been superior in comparison to CABG in ischemic cardiomyopathies.
Now, if the patient is ultimately diagnosed to have a chronic cor pulmonale, that means COPD, or patient is having ILD, interstitial lung disease with severe pulmonary hypertension with right heart failure, that can be the similar picture like what we are seeing in this patient also. Dr. Sinha, what will be your take-home message that further investigation from pulmonary side? What is the role of HRCT or PFT or DLCO? What are the utility of these three things from your point?
HRCT is definitely going to help us into ruling out other pathologies. VP scan is going to help us again. And I will specifically stick to the HRCT first because this is commonly available. Of course, the dosage is going to be very high to the patient, but it's going to help us to rule out a lot of pulmonary pathologies like pulmonary embolism, infarction, and it's going to help us in evaluation of almost all the causes of pulmonary situations. So I will stick with HRCT first. VP scan, yes, secondary, but I'll go for that HRCT. And D-dimer is something which I always follow in my patients of dyspnea, and I have always been doing repeated D-dimers, and that helps in my evaluation. That is two things which I always stick to in my clinical practice. The rest, I believe.
May I ask one question? What is your threshold of doing CT pulmonary angiography in D-dimer, persistently high D-dimer? Suppose a D-dimer is coming persistently more than 1,000 picogram per ml. So what is your threshold of doing CT pulmonary angiography? Because I have seen so many patients with a pulmonary embolism, small vessel pulmonary embolism, which is quite common after the COVID era. So that may end up in CETPH and leading to heart failure, specifically the right heart failure in ladies, specifically like this patient.
That I am not doing that, so I don't think I am the right person to answer that question. That is.
If the patient is persistently hypoxic or his HRCT is showing ILD-like pictures, or the patient there is suggestion that the pulmonary pressure is not coming down even after correction of hypoxia or heart failure, that means pulmonary pressure is persistently high, then I think better to go for a pulmonary angiography also to evaluate the pulmonary circulation, and that will be better for long term. Otherwise, this RV, if goes into a failure state, chronic right heart failure, most of the time prognosis becoming a devastating thing, because persistent right heart failure is really a bad thing. When a drug treatment or device treatment for right heart failure is definitely, we are at the beginning still now. Most of the assist devices, even CRT, CRTP or D, anything, outcome is not so good with right heart failure. So from that point, we should evaluate during this index event so that in future we should be more comfortable. And last thing, I will ask Dr. Sharma to comment on regarding nutrition of this patient in future, because this patient has a chance that they become cachectic. Particularly if you are co-prescribing dapagliflozin, the chance of becoming weight loss is too much. What will be your nutritional prescription and exercise prescription from your point?
Definitely, Professor. Such type of one patient is at present we are having in our hospital regarding what you are telling about the regarding CTPA. So this patient, if I am just coming to the nutrition part after one line. because this patient is having creatinine is more than 2.8 and these things, but this patient is having recurrent atrial fibrillation and precipitating heart failure. In spite of all the things, we are unable to control the patient. But because of the increased creatinine level, we are unable to go for the CTP. What will be the, in such cases, how to proceed accordingly?
Now you can go for a VQ scan, that is whether there is a probability of pulmonary arterial occlusion, you can identify it. If the threshold is high, then you have to take the risk and go ahead. Otherwise, a VQ scan is a good supplement for this raised creatinine patient.
Okay, because that D-dimer is more than 10,000 in that patient. In spite of all optimization, patient is still symptomatic.
Raised creatinine, go for VQ scan first. If that investigation suggests that you have to go for it, then go with high risk consent, and nephro team should be ready to tackle the procedure.
Diabetic background, patient is having an uncontrolled diabetes for more than 15 years. So CKD background is little bit there. And regarding comes to the nutrition and this thing, in such type of patient, definitely the patient if there is a dapagliflozin and these things, high chances of the catabolism and these things. So we have to take care of the nutrition part also, because in all the diabetic phase and the patient is having a congestive cardiac failure. So a good part is also we have to take care of the nutrition. So we have to take care of the support from the nutritionist, and we have to take care of the urea creatinine part whenever we are giving the diuretics in high dose, specifically the torsemide or the Lasix or torsemide.
So non-pharmacological part, that means his sleep-wake cycle, drug adherence, and nutritional prescription and exercise prescription that are very much important during discharge. So discharge checkpoints should have include these points also regarding his diet, lifestyle, water intake, salt intake, and everything. I think our time is going to be finished because we should finish at 3.
Yeah, it's already up, I think.
So we should stop here because our presentations are very good and discussion is also, I think, acceptable to everyone. So thank you all. Thank you all. We can conclude here. Dr. Munna, we are not seeing you, and okay, I think Dr. Munna Das has left, I think. So we can conclude it here. Thanks again to
I'm here, sir.
Munna, you give the final comment. You are not audible and visible. So give the final comment to conclude this session.
No. The final comment is that in this patient of ADHF that we discussed just now, the initial diagnostic dilemmas should be sought out, and realistic investigations that we can afford in our country, we should do based on certain blood tests, the risk factor evaluations, the severity of the heart failure assessment, and imaging modalities, ECG, echo, chest X-ray. All these things can contribute. Apart from that, the basic management tools to relieve the patient, and then work up for the cause, and a long-term strategy to decide this patient's overall good prognosis. That has to be ensured. The DMRDs should be in place, and that be followed up heart failure. So the patient goes to the community with a clear-cut advice and a strategy of how to the non-pharmacologic ways of how to deal with his disease, and the pharmacology itself, as also a regular follow-up of such patients. Thank you.
Thank you. Our task was to establish the clinical scenarios and discuss that area. I think next talk will be on that, what you are wanting now. Thank you. Thank you all.
Thank you, all the speakers and the respected chairpersons and panelists.